Hello, and welcome to another 10-minute topic. Today we're going to be talking about DOACs and managing patients who are taking them. So the aims of this short session are to have a brief recap on what DOACs are and when and why we use them, and importantly when we don't, and also how to manage their use in patients in various scenarios that you're likely to see in your group of patients. So we have 4 drugs that we talk about as DOACs. They're Edoxaban, Rivaroxaban, Apixaban and Dabigatran. I've put this slide up just so that you can appreciate that they have different brand names which the patients may know rather than the actual drug name. So how do they work? The Zaban drugs, that's Apixaban, Rivaroxaban and Edoxaban, are factor Xa inhibitors. Meanwhile, Dabigatran is a direct thrombin inhibitor, or factor 2A. So we can compare these mechanisms of action to heparin and low molecular weight heparins, which inhibit both of these factors to varying degrees, depending on which heparin you're going to use. And you can also contrast it to warfarin, which works through a completely different pathway, inhibiting vitamin K-driven production of factors 2, 7, 9, and 10. So the indications for these drugs include non-valvular AF. Just to be clear, valvular AF is that caused by mitral valve disease, usually mitral stenosis. It's also licensed for acute and long-term treatment of thromboembolic disease, so DVTs and PEs, VT prophylaxis, and it is worth knowing that Rivaroxaban is now licensed at a very low dose for secondary ischemic heart disease prophylaxis. So you may see a 2.5 milligram dosing as part of their sort of aspirin and statin bundle. Specifically, these drugs are not licensed for mechanical heart valves. DVTs are unusual sites, so coronary venous thromboses, upper limb thromboses, and so on. We do still use them in hematology, but they're not licensed. And importantly, antiphospholipid syndrome, and we know that DOACs for most patients are not as good as warfarin in this particular syndrome. Laboratory slide, really quick, promise. The clotting results you'll see with DOACs don't really correlate with the level of anticoagulation present in the patient. So I wouldn't use your PT or APTT or INRs as a guide. If you want to monitor these drugs, what we do is send an anti-10A level and make sure the lab knows which drug the patient is on, and this can estimate the amount of the drug that's in the bloodstream. Now these tests are very good if the patient's anticoagulation is extremely low or extremely high, but the middle area is not very precise. So we do have to take these results with a pinch of salt. So let's look at the potential for reversal. So Dabigatran now has a direct reversal agent, and this is a drug called Praxbind. It has a formal name as well, which you can try and pronounce if you wish. The other 3, the 10A inhibitors, don't have a direct reversal agent on the market at the time of making this. Andexanet alpha is a drug you may have heard of. It's been coming to the market for several years now, and we are hoping to see it fairly soon, albeit at a cost of about £11,000 per dose. So when you do see it on the shelves, bear that in mind. So at present, we're using the warfarin antidote prothrombin complex concentrate, which you may also know as Octaplex or Beriplex. And often the hematology team will advise using that along with tranexamic acid. So PCC is not licensed to reverse DOACs, and it's important to be aware that it doesn't fully reverse DOACs. That said, the outcomes after PCC when you bleed on a DOAC seem to be similar to when you bleed on warfarin and are treated with it. So the mortality rates and survival outcomes seem to be similar, so perhaps it doesn't make too much difference. So why not just simply use warfarin instead? It might be a bit cheaper, it's well established, and there are some patients that have been on it for a long time. The big plus points of DOACs are that we don't need to monitor them. whereas warfarin you need to do frequent INRs. Compared to warfarin as well, there is at least as good a bleeding profile. It's likely that DOACs have an improved bleeding profile, but that can't be proven because of the nature of the studies done. And the DOACs are more stable in the bloodstream, so they don't tend to go up and down in terms of their levels like warfarin does. And this probably accounts for their better safety profile. Another big plus point is that the DOACs have far fewer interactions with drugs and don't interact with food at all. So your patients on warfarin can have quite different INRs depending on what they've eaten in a particular week and what drugs they're on, whereas with DOACs that doesn't really tend to happen. And the shorter half-life of the DOACs, which is about 18 hours compared to warfarins of several days, does make procedures a lot easier to plan. So you can stop the drug one day and do your procedure the next day, whereas with warfarin we're talking about stopping a week before and using low molecular weight heparin in between, which becomes a lot more complex. Let's do some cases. So we have an 83-year-old male. He's had a fall and had a head injury. Comes in with a GCS of 12 to A&E and some right-sided weakness. Past medical history of AF, benign prostatic hyperplasia. He's got some osteoarthritis and glaucoma. So he takes Apixaban 5 mg twice a day, tamsulosin, finasteride, and some PRN paracetamol. His CT head shows a large acute subdural hematoma. So what do you want to know with regards to his Apixaban? What I want to know is when he last took it. So this patient, let's say he took his last dose 8 hours prior to admission. How are you going to manage him acutely? So you can pause the slide here and have a think if you want. Well, you're going to stabilize him. You're going to call a neurosurgeon and make sure that they do or do not want to do any active procedures, and then you're going to call a hematologist for reversal. So tranexamic acid and prothrombin complex concentrate are likely to be offered. I would give full dose PCC, so that's 50 units a kilo or a maximum of 3,000 units in males, but always check the protocol. The reason I do this is because he's had his Apixaban 8 hours ago. There probably is still some in his system, so there's something to reverse. These drugs, because they're taken every day or twice a day, the half-lives are a lot shorter. So if his last dose was 28 hours ago, I may not be so keen on reversing, because PCC is not risk-free. This might be a good time to think about doing a level. Okay, so restarting. He is stabilized. He's admitted, he's been in for a few weeks, he's had his rehab. When would you restart his Apixaban? Would you restart it? And what tool could you use to help assess his AF stroke risk? So you can use the CHADS-VASc score to assess the likelihood that someone will have a stroke on an annual basis because of their AF. As the score goes up, so does the annual risk. What you need to do is make a risk-benefit decision. We don't have a crystal ball. There is no answer that will guarantee a result. Okay, you're simply playing the statistics here. If he is a frequent faller, that needs to be taken into account. For this patient, if let's say he doesn't fall frequently, I would restart his Apixaban. I'd give it a few weeks, make sure that we're happy that his subdural hematoma has stabilized, and then restart. But this should be guided by hematology. Okay, so let's talk about dose reductions. So this poor chap, he's having a bad year. 6 months later, he's admitted with a chest infection. He's got a urea of 13 and a creatinine of 224. His baseline has been slowly reducing, so this is more likely to be a chronic renal failure with perhaps a bit of an acute on chronic feature. And he weighs 66 kilos, so he's a bit on the light side. So what does this mean for his DOAC? Just take a second and think what you would want to do with him. So to me, this is time to reduce. With Apixaban, we can go to a lower dose of 2.5 mg BD, and it's worth knowing that all the DOACs have a lower dose. So it's worth checking BNF or their SPCs and checking that you know the lower threshold. So the reason we do this in renal failure is to avoid accumulation of the drug, because if that drug builds up in the bloodstream, then we will have an increased risk of bleeding. Procedures. So elective procedures, very easy. Simply stop 1 or 2 days before, just like you would with low molecular weight heparin. Very simple. Figuring out whether it's 24 or 48 hours can be done using the bridging guidelines. You can find these on the Doctor Toolbox app or on the UHL guidelines website. For emergencies, call a hematologist, because really what we need to decide is, are we going to give PCC or not to reverse it? Okay, second case. We have a 55-year-old female. She develops DVT in her leg, which then embolizes to the lungs. She's treated with low molecular weight heparin for 5 days, then switched to Rivaroxaban. When you switch from low molecular weight heparin to a DOAC, just remember there will be a loading dose for a certain amount of time depending on the exact drug. So with Rivaroxaban, it's usually around 3 weeks, and it's at a higher dose, so 15 milligrams twice daily, and down to a once daily dose. So just always double check the BNF when you're switching. Okay, so her clot's unprovoked. How do you want to investigate? You can pause the slide again and just take a minute. So a typical screen that we may do in the thrombosis clinics is to do some imaging to exclude malignancy, so either a CT scan or an X-ray and an abdo ultrasound. A JAK2 screen to look for polycythemia. A PNH screen, that's paroxysmal nocturnal hemoglobinuria. Don't worry, I won't test you on this. And an antiphospholipid screen as well, extremely important. Thrombophilia screens, whilst relatively popular in GPs and obstetrics and gynecology, are less used because they don't tend to change management very much. So this lady develops another DVT a year later. Again, it's unprovoked. How do you want to manage her this time? What are we going to send her home on and tell her GP? Just take a minute to think about it. Personally, I would give her 6 months of full dose Rivaroxaban again. Seemed to do the job last time. Then I would switch her to 10 milligrams lifelong. So this is the latest thing we can do with DOACs that we couldn't do before, which is to give long-term maintenance doses at a lower dose. This has the advantage of reducing her risk of having a bleed from the drug, but doesn't seem to have any change in efficacy or protection against further thromboses. And we are able to do this with all of the DOACs now. Okay, final point is patients that have cancer. So DOACs have been investigated properly with trials in cancer now and are found to be safe and effective alternatives to low molecular weight heparin. Bear in mind, warfarin has been found to be less useful in cancer-related thrombosis. The exceptions to this are people with GI malignancies and some genitourinary malignancies, and that's because there does seem to be increased bleeding rates with these ones compared to low molecular weight heparin, but for everything else, DOACs are perfectly safe. I tend to keep patients anticoagulated as long as they have the cancer, so until cure or not, or until there is a contraindication to anticoagulating them. Finished. There's a lot of information on here, I appreciate that. The SPCs for these drugs on medicines.org are really useful. I would definitely advise having a look through them if you haven't encountered DOACs before. There's also lots of trust guidelines on DOACs. See the UHL guidelines and policies website, or use the Doctor Toolbox app, which has all of these guidelines uploaded onto it. Cheers.